colonoscopy for colon cancer, that means it can, if there is a lesion, it can identify, right? But if you take something like CEA, the carcinoembryonic antigen, that would be a screening test, right? You can do CEA, but CEA will not always be correct. So if you are going to assess how good CEA is in screening people with colon cancer, then the gold standard will be colonoscopy, something like that. So these two columns are identified by the gold standard test, right? Then what we do is we do both tests. Like we give whatever the screening test, and we also do the gold standard test in that population, right? Then we make this chart. So gold standard test will tell us whether they have the disease or don't have the disease. Now our screening test will have a positive outcome or a negative outcome. According to that, we can fill these four uh, columns and rows. So how do we calculate? So the first thing is sensitivity. Now sensitivity is the probability, or it's the probability that a patient with the disease will be test positive, right? So patient with the disease, out of the total number of people in this column. Can you all see my cursor?
Yes, sir.
Yes, yeah,
This,
we can see.
you can see this cursor, right?
Yeah, yeah.
Okay.
Yes.
So out of all these people with the disease, how many will be identified as a positive case by our screening test? So that is the meaning of sensitivity, the probability that a patient with the disease will be test positive, right? So if there are in a given sample, let's say in a population, there are the gold standard test will say there are out of 500, there are 150 people with the disease. So this total will be 150, this column here. Then our screening test will say identify only 100 out of that as positive, right? So then the sensitivity of that will be what? The true positives, like will be, it has identified 100, but there are a total of 150. So it will be somewhere around 66%, like that. So that is sensitivity, right? So higher sensitivity tests are good as screening tests since they rule out negative cases. Now, sensitivity, we say, okay, these tests, it is the ability to identify positive cases. So in screening, our target was to identify people with the disease in their very early phase, right? So we want to identify people with the disease, positive cases. So for screening, we need very good test with very good sensitivity, right? Is that clear?
Yes.
Yes.
Okay.
Yes.
All right. Okay. So for screening, we use tests with very high sensitivity. So they are the best. Then we come to specificity. Specific means the probability that a patient without the disease will be test negative. So in other words, it means how good is the test at saying that someone does not have the disease, right? So the specificity is important when we say, tell a patient that you don't have the disease, to rule out someone, like think of confirmatory tests. So confirmation now, think of HIV, right? So if we are doing HIV, the HIV confirmatory test has to be like 100% correct in saying that someone does not have the disease. So if it has these false positive ones, like it is not good at saying someone is proper negative, so we will mark people without HIV as having HIV, right? So that's a serious issue. So for a confirmatory test, to confirm something, we need to have tests with higher specificity. So they are good as confirmatory tests, right? Is it correct? Understood?
Yes.
Yeah, I hope so.
Yes.
Yeah. So then these two things, the sensitivity and specificity, they are these intrinsic characteristics of a test. Like it is a measurement of how good the test is, and it depends only on the test parameters. Right? Now we have these two things like positive predictive value and negative predictive value. So that means now positive predictive value is the probability that a patient with the positive test result actually having the disease. That means like if you take this column, like all these, both these groups will be test positive, right? This test, the screening test positive, but only this group will be actually having the disease. So positive predictive value means out of all the people who have this test positivity, how many are actually positive? Only this, sorry, only this part, right? So A divided by A plus B. So that means the probability that a patient with the positive test result actually having the disease. So that means, let's think, you do a screening test and you get something like get a positive result, right? But we know from calculation that positive predictive value of that test is 70%, let's say. So that means out of all these, if there are 100 here in these both here and here, right? Only 70 out of that will actually have the disease. So even if you get a positive result in the screening, right? There's a 30% chance that you actually don't have the disease, right? So that is a measurement of the test, right? So think now, I have said here, it is directly proportional to the specificity and prevalence of the disease. Now, if the disease is very prevalent, like let's say there is, let's take two examples, one where there are a disease prevalence is 40%. Now that means if you take 100 people from a population, 40 of them will have the disease, right? So when in the example where there are 40, and let's take another one where there are 80, right? If you look at this column, already there will be only 100, right? The total will always be 100. So if there are 100 and there's an occasion, there are only 40 people having the disease, this column. So a positive predictive value you will get some number, right? Then there's occasion, there's 80% of the population have the disease. So that means it is double, the size is double compared to the previous occasion. So the higher the number of positive actually people having the disease, your positive predictive value is going to be very high. Is it clear? Is it understood? Like higher, simply this, if your prevalence is very high, this number A is going to increase, right? So when it increases, your positive predictive value increases, right? Because this will become smaller with this because the total is going to be low. So positive predictive value will increase with the rise in prevalence in the population. So when you apply a screening test and you know that there is a higher prevalence in the population, your test is going to give you better results. The screening test is going to have a higher positive predictive value. Is it clear? Is it like confusing? Can someone just tell me like what I said? Is it clear?
Yes, sir. Clear.
Yes.
Okay. So I mean, this is just this is all just theory. Like whenever you get a question in the exam, always draw this box. Right? Always draw the table and mark these sides, and then start on making your calculations, because if you properly draw the table, it will never be wrong. Like you will never get a wrong result. So you can use whatever the letters you want. Now I have used this A plus C, whatever you can use, and just I understand the concept. So without, completely trying to memorize everything. And in the exam, usually uh, they won't, they can give you, I haven't seen recently any question like this, but they can ask you, okay, what is the positive predictive value, or a number calculation out of this. But recently it has not been asked. And if they ask, you will always get the right answer if you draw the table. So always make sure that you get that pen and paper. So draw it and then calculate whatever is necessary, right? So in simple terms, just know this sensitivity and calculation of specificity. Sensitivity, higher sensitivity is needed for screening tests. Higher specificity is needed for confirmatory tests, right? Positive predictive value and negative predictive value depends on the test and the prevalence of the disease. So it is saying how good a test is. So positive predictive value tells you out of all the test positives, how many actually have the disease. Negative predictive value tells you out of all the negatives, like how many actually does not have the disease, right? So these two are measurements of the test, how good the test is, saying, so you can depend on their result, right? So I think you will understand this much better when you do some questions. So otherwise it will all be just theory. So I will give this note, I will share this. So there are some things I have added here. So this is one such example. So this was out of a real study that was done to identify how good ultrasound is in when used to diagnose traumatic lens dislocation in acute situation, trauma. So this chart, if they ask you to calculate sensitivity, so sensitivity means here, so lens dislocation, positive and negative. Now this is the gold standard, right? This is your ultrasound results, positive and negative, this way. So sensitivity means out of all the true positives, how many were identified by the test as positive ones. So here 13 cases have lens dislocation, and ultrasound was able to identify 11 out of them as positive. So if they ask sensitivity, it will be 11 out of 13, right? Specificity is out of all the negatives, like how many were identified by the test as negative. So they identified 115 as negative. So we had a total of 117. 115 divided by 117. So that is sensitivity. Just like that, positive predictive value also you can calculate this way, and negative predictive value calculate this way. So this is also again the same thing illustrated in a different way, right? So just go through some examples. If there are any issues, you can, if there are like serious issues, you can reach me via Dr. Sajid or someone from the group. Okay? Do you all want me to tell anything regarding this again, or is it like sort of clear? Confused? Did I make you all confused?
Very
No,
clear,
sir.
sir.
Yes, sir.
Okay, so if there is any issue when you are doing any questions, you can ask.
For the sensitivity, we are
Sorry?
higher sensitivity for screening test.
Yeah.
And
Yeah. So sensitivity means the ability of the test in identify these positive cases. So as I said, when you screen, the target of screening is to identify people with the disease in their very early phase, right? So what we need is a test that is good at identifying positive cases. So higher the sensitivity, higher the test's ability to identify these true positives, right? So if you are identifying, if you are deciding or if you are creating a screening test, so it should have very good sensitivity, right? So that is how it comes. When specificity means the test is good at saying, or it is good in excluding all these negatives. It is good at saying someone does not have the disease. It's very specific. If the test is negative, that means you are sure that the person does not have the disease. So specificity, higher specificity is needed when you design confirmatory tests. So you can confirm this patient does not have the disease, right? So that is the concept behind that, right? Okay.
Sensitivity and specificity are given as a number, and PPV and NPV is given in a percentage, is it?
It can be given both as a percentage or like a fraction. So because if you divide, if this is all numbers, like what you will get is a fraction here. So you can multiply by 100% and get the percentage value. Okay, I have not, see now here, if you had numbers like this is 40 and this is like maybe 70, something like that. So it would be 40 divided by 40 plus 70. So 40 divided by 110. So that you can again, if you divide, you will get a fraction, and you can multiply that by 100% to get a percentage, right? So it can be given as a fraction or a percentage. So we usually use a percentage. I have not included the percentage by 100, the notation here. Usually it's a percentage, but giving it as a fraction is also not wrong, right? Okay, then we come to this part. How do you decide on the cutoff value for a screening test? Now, I will put this one here. So I said when you design a screening test, first what we do is we get a sample of a certain group of people from the population, and we do both the tests. We do the screening test, whatever we are designing, and we do the gold standard test, right? And then we can identify people who are truly who have the disease and who don't have the disease, right? So these two, now this group is the negative group. So how do we identify this? This is by doing the gold standard. It will say these are people who don't have the disease. These are people who have the disease, like positives and negatives. Okay. I think this like sort of 3D like picture you can see properly. So how do we do is that now when you do the cutoff, now think of something like, okay, appendicitis and CRP, right? So it's a commonly used thing. Now people, you can see that a patient comes with right side lower abdominal pain, there is tenderness and maybe fever. Then you do CRP, you get a certain CRP value, right? So CRP we can use as a screening test. Then what is the gold standard thing? It is you do surgery and send for histology. What does the histology report say? Let's say this is laparoscopic. So laparoscopic appearance of the laparoscopy is the gold standard, right? Now, after doing surgery and identifying, we will mark these people had actually had appendicitis. These people did not have appendicitis, right? So that is that. Then CRP value, we will mark all those patients according to their CRP value, right? So you will see some people, some patients who had appendicitis had negative CRP or a lower value, right? Let's say usually people, we use 6 milligrams per deciliter, right? As the cutoff. Now, less people with appendicitis may have lower CRP value. CRP may be normal, right? And there will be patients who actually don't have appendicitis, but their CRP will be elevated, right? Maybe for some other reason, right? So when you use that, there will be an overlap. If you can see now this cutoff when drawn, this negative people, there's a small part where there are a group of negative ones that are marked as positive. Then there's a set of people marked as negative, right? So we will come to this one now, right? So here, just for the time being, only think of this curve, this prevalence 1, this dark, this black color curve. Forget about this prevalence 2 and prevalence 3, these things, right? So when you do CRP and mark the people who underwent surgery, you will find, okay, there will be an overlap, right? Some who didn't have appendicitis may have CRP higher than some people who actually had appendicitis, right? So you will get a curve like this for negative people, then you will get a curve like this for positive people. Now you want to identify what is the best CRP cutoff to identify appendicitis. Okay, then first we will take this cutoff 3. Say, let's think this. Okay, we will say this is CRP of 6. This is CRP 7. This is CRP 7. This is CRP 8. So cutoff 1 is 6, 7, 8. Now we have drawn the graph. Now it is okay. We think about CRP 8. If we take this cutoff, like everything on the right side, this way will be positive. Everything to this side will be negative, right? So let's look at what is on the right side. If you take this cutoff, this part, this red dots, including this part, is what is on the right side. So everyone here is a positive case. These red colored dots are positive, right? So if you take the cutoff of CRP 8, everyone on the right side will be positive. Okay, so that is good. Then look at who are the people who will be marked as negative. On the left side, you have everyone who actually don't have the appendicitis, and there's a group of people who actually have appendicitis, but since we use this cutoff, they will be marked as not having appendicitis, right? So that means if we use this CRP8 cutoff, we are going to miss some patients with appendicitis. Is that clear?
Yeah, very clear.
Yes.
Thank you.
Yeah, okay. So, so 8 is not a good cutoff for screening value, right? Then let's take this one. What about CRP7? Now we come here and everything on the right side is going to be positive case, marked as people having appendicitis. Again, if we look here, okay, there's a whole lot of positive cases, the red color dots, and a very small number of negative cases who are going to be marked as positive. Okay. So if you take this cutoff, there's positive plus negative, and on who will be marked negative? Negative ones, we have these negative cases up to here, and there's a small number of positive patients. Okay, that means people who have appendicitis, but they will be marked as not having appendicitis. So here also, we are going to miss some people, some patients who actually have appendicitis. So that is not good, right? So what we need is we need to identify everyone with the disease, right? Then we take, let's look at this, the cutoff 1. If we take this one, the 6, then on the right side of 6, we have everyone with appendicitis, right? So there's no one on the left side. So that means good. 100% of the appendicitis cases are on the right side. So if we take this cutoff value 6, all the positive cases will be marked as positive by using CRP. At the same time, some patients, some negative cases will be marked as positive, right? But it is okay because why? Our aim is to identify everyone with the disease without missing, right? So in actual clinical situations, you may have a patient, there may be a patient who comes to the PCU, right? So at the PCU, you do CRP, then it comes as 6, and let's say this is just an arbitrary value, right? So comes as 7, right? Then that one you decide that you need to admit, right? Because it's elevated, right? So there will be some negative cases who have 7, but it is okay because we are going to do a confirmatory test later. CRP is not the only thing we are going to do. We will do imaging after admission, right? So, but at the OPD level, PCU level, CRP is going to be a good screening test there, right? So, what we need to do at the screening is to identify everyone with the disease, all the positive cases. Does not matter if we involve some negative cases, we can rule them out later on by doing a confirmatory test. Is it clear?
Yes.
Yes,
Yeah.
sir.
Yes.
Yeah.
Yes.
So then you might have a question, okay, what about CRP5 then? If we use CRP5 also, then again, CRP5 also will mark everyone with the disease as positive, right? But the problem is now we will have more negative cases who are getting marked as having appendicitis. So that is not what we want. So if you have multiple points given in the exam, you will get, so this has been given before also, this question. So if you get multiple points, which will include 100% of the cases as positive ones, use the point which has the least number of negative cases included, right? So here, if you use 5 also, so 5, 6, both are good, but 6 will have the lowest number of negative cases included. So that is how you decide on the cutoff value. Okay. Is it clear?
Yes, sir. Thank you.
Yes.
Okay. Then now the question can be asked in different ways, right? So if they ask what is the best screening test or what is the best test to identify the positive cases, this cutoff 1 is going to be the best thing, right? Or else they might ask, okay, this is some random test is being designed, and what cutoff will give the best balance, right? So if they ask about the best balance between sensitivity and specificity, it will be 2, right? So it's in the middle. So it will give a good balance. Both sensitivity or specificity won't be 100%, but it will be somewhere around 90. So it will have a good balance, right? And if you want a confirmatory test, it is going to be this, right? So because now when it comes to confirmatory test, you need to rule out everyone, but don't go by that. Just by this chart, it has some steps that need to come before that. So we are only worried about this screening test cutoff values here. So it will be like this. If you want, look at the point which includes everyone with the disease, right? That is going to be your cutoff value, the ideal cutoff value. Does not matter whether you have some negative cases included, because they will be later on ruled out by a certain confirmatory test, right? If you have multiple points, similar multiple points that include everyone with the disease, use the point that includes lowest number of negative cases. Okay. So I think that is clear. Okay.
Yes.
Yeah. Okay. So, okay, then we will go to the next topic. So we have, up to now, we have discussed these prevention strategies. Then what are the values, the sensitivity, specificity, the meanings of these things? Then how do we decide on a cutoff value for a screening test? So this part, this concept you have to know very well. This has been asked multiple times. So it will come most likely come in the exam too. So know that, right? So then the next part is the hierarchy of evidence. Hierarchy of evidence means now we have multiple studies types that we do in clinical situations. So there are a lot. So what is the best thing that we can base our opinions or our decisions on? So that depends on this hierarchy. So here, the lowest case that we are interested in this discussion is this case series and case reports, right? So they are at the bottom. That means they have the lowest quality of information. So a case series is just something that many of you have read, many of you have come across, maybe you have also written case series, but it is just experience from a single treatment unit, right? Where you give or you publish your experience to the rest of scientific community to see, right? So then when we go above, we have this cross-sectional studies, case control, cohort, randomized control trials. And these are studies. These at the very top are the filtered information that come from these, right? So we analyze multiple multiple studies from here, and we gather the information in a filtered and structured way and publish these. So at the top is what we call meta-analysis. So they are this level 1 or the top evidence. the best quality evidence that we can base our clinical management on. So all these guidelines, recommendations that you see, most of them we come across these meta-analysis and systematic reviews, right? So this hierarchy you will have to know, because there are questions that ask, okay, you want to do this, let's say they will give a clinical question and just ask what study will give you the best evidence regarding this. So whenever they ask a study for you to do, remember this hierarchy, these 5, and select the best one. The top one is always this one, right? So I have seen 1 or 2 questions like that being asked, not very frequently, but it has come, right? So that is that. Then the higher the quality of information, the more we can depend on them to guide our management. That is the basis. Okay. All right. So these studies, now we have this clinical research studies. So there are 2 main types. So you have experimental studies, so these interventional ones, and you have observational ones. Observational study means the researcher is not doing any intervention. He is just looking at the population and he is describing or analyzing what he sees in the population. That he only that. He is not going to do any change in the population. He's just looking at what is happening, and then he's describing or analyzing what he sees, right? Experimental study means where the researcher will do some intervention. He will introduce a drug, he will introduce some other procedure, something, and then he will analyze the outcome. So that is simply the difference between these 2 groups. So for our use, for this exam use, we need to know this cross-sectional study, case control study, cohort, and clinical trials. These 4. Those 4 are the most important ones that are being frequently questioned. So we will discuss those 4 in a little bit of detail. So case studies, as I said, it's a detailed description of management of a complex or atypical clinical problem. Usually, a case series is multiple of case studies, similar case studies, right? So they are used to describe rare presentations from a common disease or rare disease presentations, right? So you may have heard of this HIV and AIDS epidemic. It was initially identified through a case series like this, written by 2 doctors in USA. So it's important. The case series are important in a manner that we can design other studies later on to properly identify things. So case studies are a starting point. Okay. So it's just knowing that is enough about case studies. Then we come to cross-sectional studies. Cross-sectional study means it's also called the prevalence study. Now, cross-section means at any point in time, you will just look at the population at a certain time and describe something that you see, right? So this measures the prevalence of a disease. Now, prevalence means how many cases are currently there. Now, today, if we want to look at some disease, maybe pneumonia, maybe diabetes, whatever, prevalence means, okay, I want to check how many cases of diabetes are there in certain district in Colombo, like that. So that is going to be a cross-sectional study. There is no follow-up, right? There is no data collection into the history or into the future. So just at this point in time, what is the picture? That is a cross-sectional study. So we can't measure incidence. Incidence means how many new cases are developing, or directional. Directional means of association. So smoking causes lung cancer. When you say something like that, in a prevalence study, you will see people who smoke and there will be people who have lung cancer. And people with lung cancer may have the habit of smoking also, but we can't say smoking caused lung cancer. So because this is only a prevalence study, right? So if it was some follow-up study, we may have the ability to say that there is smoking actually caused lung cancer, right? Are these things clear? I'm saying, like, is it okay? Do you want me to say again?
Clear, sir.
Okay, all right. Okay, so
Cross-sectional study,
yeah.
your example can't find how many new lung cancers occurred in 2022 Victoria. Can't we find it? We can find it now. Cross-section wise,
So
during that period, how many new? So we can find it, isn't it?
no. It's like this. Now, a prevalence study is now, if you want to identify how many lung cancer cases occurred in 2022, right? That means either you have to start at January 1st of 2022 and follow up till December 31st to see how many new lung cancer cases occurred within that given year, right? So there is going to be a follow-up. Okay. So if there is a follow-up, it is not going to be a cross-sectional study.
Okay, that's the thing, no? Right.
Yeah,
Thank you.
yeah. So that is the thing. When you see that, you can't say. But if you want, okay, on to December 5th, like December 3rd of 2023, today you want to know how many lung cancer patients are there in this state, or like that, right? And you do the study state-wise, completely within the state on the same day, right? Then on the same day, or you take 2 days and do that and see how many diagnosed cases are there. So that is prevalence. That is a snapshot, like within, at this point in time, this many number of cases are there. So that is going to be prevalence. If you want to identify in a given range, like given time period, from this day to this day, that there's always going to be a follow-up, right? So like that. So prevalence of childhood obesity, we can find that. We at Victoria, prevalence of lung cancer, we can find that. But if we need to, if we include a large time gap, there's going to be a follow-up. So that is done. Then there's something like this, like rarely this can be used to check associations when a risk factor is congenital, right? Now, sometimes you can get examples like, there are risk factors which are congenital. So when you have that picture given, you already know this is congenital. So that means the risk factor always came before the disease, right? You are sure because the risk factor is congenital, right? So in such cases, right? I think there was a question in M+X. I haven't seen real exam questions with this, but I think M+ had one like this regarding hyperlipidemia in a young girl. There was a question, I think you guys just go through that, right? It was given there. The association might be inaccurate due to other factors, right? So there are things called confounding variables. That means just because the congenital risk factor was there, we can't directly say this is the same thing that caused the disease, right? So they will say this as example, cross-sectional studies can give you causality for an outcome and give you a congenital risk factor and say now the patient has the disease. Does that prove that the disease was caused by the risk factor? That risk factor? No, we can't say that. Although it was a congenitally present risk factor, it is not always going to be correct. So there are other factors that need to be looked into, which are called confounding variables, right? So just because there are congenital risk factors, by using a cross-sectional study or a prevalence study, you can't say this risk factor caused this disease. Okay. So that this is a rare thing, but there was a question in M+X. That's why I just added this. So how do you identify that? Is always check when the exposure and outcome was measured, right? If the exposure and outcome was measured, they were measured at the same point in time, that means it's a cross-sectional one, and you can't say the association between the two factors. Okay? Was it confusing?
So basically, with the cross-sectional study, we can only say about the prevalence.
Only
That's what it
the
is,
prevalence.
right?
Okay. This many number of cases are
Okay.
there at this point in time. That's all we are going to say. Right? It can be descriptive, it can be analytic, whatever, but we can only say that part. Okay? Shall I move on?
Yes, sir.
Okay. So then the next type is case control study. Now, case and control. So by the name, you can see that there are two groups, right? So this is also called a retrospective assessment. Case control studies are retrospective assessment, where you look into the history of cases, right? So this study selects comparable case. That means case means people with the disease, and control, people without disease groups, and look into their history to see exposure to a common factor, right? Then compare both groups to check if the odds means the likelihood or the probability or chance of getting the disease was higher in people with the exposure, right? Now, this study is good to assess rare diseases and foodborne outbreaks, right? Odds ratio is the main outcome. So why we say it is good for rare diseases and foodborne outbreaks means now if there is a disease that we, let's say, only 1 in 10,000 people develops that disease, and if we want to assess that, we can select a sample of 10,000 people or 100,000 from the population, and we can follow up for 5 years or 10 years and see whether whether someone is going to develop the disease, right? That we can do, but that is going to be very expensive, right? With that to follow up 100,000 people just to identify maybe 5 or 10 cases is going to be very time consuming, and it's a very expensive study. So in such cases, the best thing is to identify people who already have the disease, then look into their history and check what were the common risk factors that they had exposure to, right? So that is why it is case control studies are good to assess rare diseases, right? Then the other one is foodborne outbreaks. Now, foodborne outbreaks, when you want to identify what may be the source, where was the infective focus in the population, finding out people and looking into the history is the best thing. You can ask, okay, where you get people who got food poisoning and ask, okay, where did you eat in these given dates, and look into their history and find out, okay, this group had taken food from a common shop or like that. So that's how it is easiest to identify the focus in foodborne outbreaks, right? Then the odds ratio is the main outcome. Now, odds ratio means, I said odds is the word means likelihood, chance, or probability, right? So what we do is we calculate these odds for the two groups, the case group and the control group separately. Then we get the ratio between among those two values, right? So the first one is odds of exposure in cases. So we have a cases group. Now what we're going to do is we take the number of cases, people who had the disease without exposure, right? And we have people who had the disease with the exposure. So we divide this by this, and it compares among the cases the risk of the magnitude of the exposure in giving the disease, in causing the disease. Is it clear? This part, the odds. Odds means what is, yeah. So what is the probability of exposure in the cases? So what we do is we take people with the disease and the exposure, the number, then we divide that by with the disease without the exposure. So we get a certain value, right? Then we do that to the control group also. In the control group, we find, okay, who had the exposure, maybe let's say a foodborne, maybe typhoid, something like that. Okay, we find people who don't have typhoid, but they have taken or bought food from a certain shop, right? So they will be in this group. Then we find people who don't have typhoid and they have not taken food from that shop also, right? The certain shop. So we divide this from this, then we will get a value, right? So the odds ratio is this odds in the cases group divided by odds in the control group, right? So the two numbers we divide, and we will get a certain number like 2, 3, whatever, 2.5, whatever a number we will get, right? Then this, I have not seen questions where they have asked to calculate the odds, but they have most of the time asked to interpret the odds ratio, right? So how do we do that? Now, odds ratio more than 1 means, now if you see here, the odds of exposure in cases, odds of exposure in control. So if you have a value that is more than 1, that means that means this part is going to be the bigger part. So we have a suspicion that there's a higher risk in the exposure in cases, because there are more people with the disease and the exposure, right? So what we are going to say is, if the odds ratio is more than 1, there is higher likelihood of disease occurring in people with exposure, right? If the odds ratio is more than 1, then there is a higher likelihood, higher chance of disease occurring in people with the exposure. Okay, but we can't be sure, because there may be a large population and we take only 100 sample of 100 people and we calculate this. So we get a odds ratio more than 1, but we can't completely say the disease occurred just because of this exposure, right? So to do that, to check whether it is statistically significant, there's another calculation that needs to be done, and that part is beyond our level. So there's a certain equation that you have to apply, then you get this 95% confidence interval, or you get a range of values where your odds ratio can include, right? Can be included. So only by using that, you can be sure that the odds ratio that you identified is significant, right? So when this calculation is done, this part is not important to us. It will be given in the exam, right? So they will say the odds ratio is something like, let's say example, like this, 0.8 to 2.4, right? So the important thing to know is how to interpret the odds ratio, right? So if the given confidence interval range crosses the value 1, okay, then the observed odds is not significant. So what that means is that this confidence interval range means, in an example, 0.8 to 2.4. That means your odds ratio can be any value in between these two numbers, right? But we know that odds ratio is significant only if that is more than 1, right? Only if the odds ratio here, if it is more than 1, then only we can say that the cases have a higher likelihood of getting the disease because of this exposure. Like if it is more than 1, that means the control group is bigger, that then the exposure has nothing to do with the disease. Okay, is that clear? Hello?
Yes.
Yes,
Okay.
Dr.
Yeah. So odds ratio is important only if it is more than 1, right? Then if your confidence interval says that odds ratio for this group can be anything between 0.8 to 2.4, that means it can be 0.8, 0.9, 0.92, 1, whatever, right? So that means this population can have a confidence interval of odds ratio of 0.8 or 0.9, right? So those are non-significant values, right? That means whatever the number you calculated, if it is more than 1, that was just by chance and it is not significant, right? So OR odds ratio equals 1 means there is no increase. So these two groups are similar, right? So how do you interpret, how do you use that is that in a question, if you get odds ratio more than 1, right? That means there is a higher likelihood or higher chance that this, whatever the exposure, has something to do with the disease, right? Has likelihood of causing the disease. But to be sure, we need to calculate this confidence interval, right? Range. So in questions, it will be given, right? It will be given. And if that range includes the value 1, that means maybe 0.8 to 2.4, maybe 1 to 2.4, something like that, then that means you can just discard whatever that odds ratio is, because it is not going to be significant. But if the confidence interval was more than 1, so it has a value maybe 1.2 to 2.4, 1.5 to 2.7, whatever. And that means, so the whole range is above 1. So that means the odds ratio is significant. Okay, then whatever the value you calculated, whatever you find is significant. So that means there is a higher likelihood that the exposure caused the disease. So getting food from a certain shop led to typhoid being spread, right? So that is how you interpret this odds ratio with the confidence interval. Is that part clear?
Yes.
Okay, right? So,
Yes, sir.
all right.
Excuse the confidence interval 1.2 to 2.4 or 1 to 2.4.
So
Yeah.
it's like, okay, so here you have what I said was your odds ratio 1, right? Odds ratio equals 1 means these two, the two groups are similar, right? So they don't have an increased odds of anything. They both had the same thing, right? So that means it is not significant. The odds ratio is significant only when you have a odds ratio more than 1, anything more than 1. Okay. Now, that having a value more than 1 will say that there is a higher likelihood or higher chance of disease occurring in people with the exposure, right? But you can't be sure. Just by having a single number from a sample, you can't say definitely this was the case, right? So how do we do that is we calculate the confidence interval, right? Now, confidence interval will have a certain range of numbers, right? A certain numerical value. So if you get something like a value below 1 and something above 1, right? So 0.7 to 1.3, something like that, or 1 to 1.4, something like that, right? So this means the odds ratio equals 1. That means the point where there is no significance in the odds is also included within this, right? That means this range can have a point where there is no significance, right? So whatever the significant value, the single number that you find from a single sample is not going to be significant, right?
Yeah.
Yeah. But if the confidence interval that has been given to you is bigger than 1, right? It is something like 1.4 to 2.7, just example, anything like 1.15, 1.2, anything to some other number. That means this range, everything in this range is above 1. So any odds ratio in this range is significant, right? Yeah. So that means there is actually a significance, statistical significance in this exposure to cause the disease, right? So in our example, whatever the people taking food from a certain shop actually led to this typhoid outbreak. Okay? That is what you need to know, because now when there is 1,000 people, you can take samples of 100. Like you can calculate 10 odds ratios for those people, each 100 group, right? So you will have odds ratios of different values, right? Therefore, since all these samples have different odds ratios, to properly statistically identify whether there is a significance, you have to calculate this. What this confidence interval says is that whatever the sample you take from the population, in whatever the number odds ratio that you get will be within this range. There can never be anything outside that. So if that range includes values of 1 or less than that, that means there are some samples of people who whose odds ratio is below 1. That means the exposure had nothing to do with getting the disease, right? So in such cases, we discard whatever significance we attribute to the odds ratio. We may have got the value as 1.4, but the confidence interval is like this. 0.8 to 2.4. That means that 1.4 we found was just by chance. It is not significant. But the confidence interval is something like this. Then 1.4 is within this, and all the odds ratios that any given sample can take will have a value above 1.2. That means it is significant, right? Okay. So after this, you guys just go through this and sort of do some questions, then you will identify. But the only thing to know is that the 2 points to know is that if odds ratio you find is more than 1, that means there is a higher chance of the exposure causing the disease, but that only depends on your confidence interval, right? That should only be analyzed after we have the confidence interval, right? If the confidence interval is above 1, then only you can say there is significant association between this exposure and the outcome. Okay, right. So that was case control studies. So case control studies, we compare two groups and the outcome we get is the odds ratio. And the odds ratio is analyzed by using the 95% confidence interval. Okay, so that is what. Then we have a cohort study. So I said before, the case control ones are retrospective assessments. So we find cases and controls, then we go back into their history and check. So cohorts are prospective. So we initially identify a group of people, then we follow them up, right? So here, so this study identifies a group of people, then follow them up for a certain period of time to check whether they will develop a certain outcome. Okay. So then we can compare the people who had a risk factor without people who didn't have the risk factor, right? So that will help us identify the causality. Causality means what risk factor led to the outcome, whether smoking caused lung cancer, whether smoking caused MI, like that, right? So just like we identified odds ratio from case control studies, in cohorts, we can identify relative risk, attributable risk, these two values, right? Relative risk and attributable risk. They are the main outcomes, right? So cohorts, because we can identify the causality, we can check for all these risk factors. Because we are following up people, we can identify the incidence. And within the follow-up period, at any point, we can calculate the prevalence, right? So we can do all these things with the cohort study. So out of all the things that we discussed, so cohort is going to be the best up to now. But it is not practical for rare diseases and diseases with this long incubation and latency. As I said before, like if the disease is only occurring in 1 in 10,000, so we can't be following up 10,000 people for 10 years just to identify one case. So that is not very economical, and it's very time consuming, right? So this relative risk, this RR, it is also called risk ratio. Okay. So example, so questions like this: what is the risk of getting stroke with hypertension? What is the risk of getting lung cancer with smoking? We can answer questions like this by doing cohort studies. So here also, so when we do, so let's say we identify a certain group of people at the beginning, then we follow them up for maybe 5 years or 10 years. Then at the end of that period, we check, okay, who had MIs, whatever the outcome that we wanted, and we look into the history and check whether they had whatever the risk factors that we wanted to identify, right? So by using that, we will create a group who had the exposure, whatever, let's say example, smoking. So people who smoked, people who did not smoke, right? Then outcome, people who got MI, people who did not get MI, or people who had lung cancer, people who did not have lung cancer, like that. Okay? Hello? Yeah.
Yes.
Yeah. So then by doing that, then the first thing is relative risk. Now, relative means when you compare something to some other thing, right? So here we compare the exposed group to the non-exposed group and see whether there is an increased incidence of disease in the exposed group, right? So incidence risk among an exposed group. So let's say smoking and lung cancer. So what we do is, so A plus B means the total number of people who smoked, and A will be the number of people who got lung cancer. So that is A divided by A plus B, right? So that is the incidence in the exposed group, right? Then people who did not smoke, right? There are people in the community who get lung cancer even without smoking, right? So C is the people who got lung cancer, but in the non-smoking group. So C divided by C plus D, this total non-smoking group. C means the people who got lung cancer who are from the non-smoking group. So this is the incidence, the lung cancer incidence in the non-smoking group. So when we divide this, we get a certain value, right? A relative risk. So if the relative risk is larger than 1, so if you get a value bigger than 1, that means this yellow color part is the big part, right? So that means there is a significant incidence. So there is a higher incidence in the exposed group, right? So if it is bigger than 1, that means this yellow color thing is bigger, right? But if it is smaller than 1, that means this blue color thing is bigger, right? So how do we how do we interpret that? I will say later, right? So that is how you check relative risk. Relative means you compare the exposed group to the non-exposed group, right? Like this, it's just a number. You will get a number like 0.7 or like that. But if you want, you can multiply by 100 and get a percentage also, right? Then attributable risk. Now attribute means like, now as I said, so when people smoke, they can get lung cancer, right? But everybody who get lung cancer has not smoked. So that means there are some people in the population who have never smoked, but still they get lung cancer, right? So when we look at the population, when we identify everyone with lung cancer, people who had smoked and people who did not smoke and got lung cancer, though everyone will be included in this group, incidence risk among the exposed group, right? Is that part clear? Like you don't have to smoke to get lung cancer, but smoking causes lung cancer. Is that part clear?
Yes, sir.
Yeah. So
Yes.
then how do we know? How can we say? How can we identify just because of smoking how many people got lung cancer, right? So that means the pure effect of smoking. We want to look at what is the effect of smoking, right? So to do that, what we do is we find the incidence among the exposed group, like people who smoked and got the disease, got lung cancer. Then from that, we subtract people who got lung cancer without smoking, right? So then it takes out that the number of people who will anyhow get lung cancer, right? Then we will be left with people who got lung cancer because of smoking, right? So attributable risk. Attribute means you assign that whatever the risk. So just here, the smoking. What is the attributable risk of smoking? Just because of smoking, how many got lung cancer? So that is what we are going to identify using this. Okay, that is the meaning of attributable risk. Then attributable risk percentage. Now this as a percentage, you can calculate this the long way also. But this what I have put here is this is a simple equation. If in any question they ask attributable risk percentage, you can calculate This relative risk -1 divided by relative risk. This is a easier way, and this is also correct, right? So now we have this relative risk, we have this RR, then we have this AR. So how are we going to interpret these things, right? So if the relative risk is more than 1, that means the risk factor increases the development of disease, right? If the relative risk means equals 1, that means the risk factor has no effect on the disease process. Like, so as I said, if you have a value more than 1, that means this yellow color part, the group is bigger, right? That means the exposure to the risk factor had a bigger impact, right? If the relative risk equals 1, that means both these groups are equal. That means the exposure to the risk factor has no effect. Okay. And if the relative risk is less than 1, if you get a value less than 1, that means the blue color group is bigger, right? So that means the exposure is actually protective. Whatever the value, whatever the factor that you are looking at, it is actually protective, right? Because the exposure to that factor has resulted in less number of cases occurring in that group, right? Now, odds ratio, we said if we can take it, or we can consider it only if it is more than 1, right? But when we come to relative risk can be interpreted both ways. So relative risk, if you have a value more than 1, that is a risk factor. If you have a value less than 1, that is a protective factor. But equals 1 means there is no effect, right? So what we do is, now from the population, we have maybe identified 1,000 people and we have followed up. Now we have calculated relative risk, right? So just like we did with the odds ratio, here also we have to calculate that 95% interval, right? Just like we did with the odds ratio, we have to calculate this confidence interval for the risk ratio also, right? Here also, the meaning is the same, right? If your confidence interval, right? If your confidence interval crosses the value 1, that means your confidence interval has a, let's say it's 0.7 to, if your confidence interval is 0.7 to 2.4, something like that, right? So confidence interval should not cross the value 1. This means it says all the samples from that population you check will have a relative risk from this value to this value. So some samples will have values more than 1. That means saying that it is a risk factor. Some samples will have values say it is less than 1. That means saying whatever the factor is protective. So you can't have both those things in the same group. It can't be a protective factor at one time, it can be a risk factor on the other time, right? So that means it is meaningless, right? So if your confidence interval ranges from like values less than 1 and more than 1, that means whatever you found out, the relative risk, that is not significant. Is that clear? Or like,
Yes.
yeah, okay, right? But if the range can be below 1 or above 1, but not crossing 1. So that is the important part you need to know, right? So it can be like 0.2 to 0.9. So this means all the samples will have a relative risk calculated between these two values, that 0.2 to 0.9. So that means everything says that it is a protective factor, right? So this is significant and this we can believe in, right? And also you can have something like this, 1.2 to 3.4. So everything, all the samples say whatever the factor we are looking at, it is a risk factor, right? So this is also statistically significant, we can say. So these two we can believe in, either to say it is a protective factor, because if a sample says that a factor is protective, all the possible samples should say that it is protective, right? If a sample says that it is a risk factor, all the possible samples should say that it is a risk factor, right? You can have a mix of two. Like if you get something like this, that means it is not significant, because you can't have some samples saying it is a risk factor and some samples saying it is a protective factor. So if your confidence interval is given as something like this, just discard whatever the relative risk that has been identified. So here there is no statistical significance. Only in situations like this, either less than one group or a more than one group, only in those situations you can interpret relative risk. Okay?
Thank you.
Yes.
Yes.
Yeah, okay. So I know this is a lot, going through we have been doing for some time. So just go through this again like a couple of times. After this, do questions, then you will identify these small points. Okay. So the last type of study is these randomized control trials. So we spoke of these case studies. Then we spoke of these cross-sectional studies. Then we spoke of case control ones. Then we did the cohort studies. So the last one is randomized control trials. So randomized control trials, I said at the beginning, it is an interventional type of study where the researcher does some intervention in the population. So that intervention can be giving a drug to a certain group and giving a placebo to another group, or doing some procedure on one group and not doing that procedure on the other group. So it can be anything, right? So this is a study where the researcher randomly assigns the exposure to participants and measures the outcome. Usually used for checking efficacy of vaccines, new drugs, etc., can determine causality, right? Randomization and blinding remove the effect of confounding factors and bias. So when we say this is randomized control trials, so randomization means why we randomize is that we want to make sure that the only thing that affects the outcome of the study is the factor that we change, right? So all other things are randomized. So at the end, when we do the calculations, those things will cancel out each other, and we will be left with only the effect of whatever the factor that we were looking into, right? So that is why we do this randomization and blinding, right? Then just like we had those odds ratio, relative risk, attributable risk in previous studies, in a randomized control trial, we get this relative risk reduction, absolute risk reduction, and number needed to treat. These three outcomes are from randomized control trials. Okay. So how do we calculate these things? So these are the equations, and what do these things mean? Now, relative risk reduction means, I said relative means always comparing to another group. So what we do is we compare the difference. We take, okay, let's say we had a group who got aspirin. So this is the common thing, right? Question that has been asked multiple times over the last few months. So you have two groups. One group gets a placebo, the other gets aspirin. So then At the end of the study, they will check the outcome, the number of MIs that people got, right? So relative risk reduction means, so you check the incidence in the untreated group or the group that got the placebo, and you subtract the number of MIs that the treated group, the people who had aspirin got. So that gives you the difference between the untreated group and the treated group. Then you divide that by the incidence in the untreated group. So compared to the untreated group, what was the risk reduction, right? This difference is the reduction made by this, right? So that is relative risk reduction. So like this, the percentage of reduction in disease occurrence risk achieved by the new treatment or intervention compared to the placebo group. If the relative risk reduction is 50%, that means a person treated with aspirin will have 50% reduced risk of having an MI compared to a patient not, I'm sorry, this should be aspirin. This is a typing mistake. Not ACE inhibitors, should be aspirin. Right. So compared to a person not treated with aspirin, a treated patient will have 50% less risk. So like that. So the sentence or the wording saying relative risk reduction of 50% means a person who got the treatment has 50% less chance of that disease or outcome occurring compared to someone who did not get the treatment. Okay. This I will describe in more details. I have this example below. So look at this one. So here, this is the group that did not get aspirin. This is the group that got aspirin, right? So at the end, so this study, you can read on this. I have included the link. This was in a BMJ article. So there's a very good explanation of understanding these numbers, risk numbers, right? So people who did not get aspirin had 2 MIs at the end of the study, and people who got aspirin had only 1. So that means 2 here has become 1. 2 becoming 1 means a reduction by 50%, right? In simple terms. 1 is half of 2. So it is from here to here, it's a 50% reduction. Just by looking at this, you can say that. Okay. Is it clear?
Yes. Yeah.
Yeah. So that is relative risk reduction compared to the people who got treated, right? Compared to the people who didn't get treated, what is your chance of getting? So if 2 people in this group gets the disease, only 1 in this group will get. That means in this example, it's 50%, right? So it's comparative. Then you have something called this absolute risk reduction. Absolute means always a number, right? Number of people per 100. That is how we do that. So the absolute number of unfavorable outcome cases that can be prevented, right? Absolute number of unfavorable outcomes. So here MIs. How many MIs can we prevent when we treat 100, right? So if it says, now here, absolute risk reduction. So you check the incidence in the untreated group and you the treated group, and you subtract the value. So you get a difference. So that is the prevented number of prevented cases. So if absolute risk reduction is 1, that means when 100 people are treated with aspirin, 1 case of MI can be prevented, right? So when you look at this also, you can say, so all this, there's 100 here. When you treat 100, right, 1 case has been reduced, right? So you treat 100, there is 1 person who did not get a MI. So that is the absolute risk reduction. It is 1%, right? As a percentage, if they ask, it is 1%. As the number, it is 1. When 100 are treated, you prevented 1, right? So that is absolute risk reduction. then the number needed to treat. So now, if you may have gone to these like clinical sessions, and this college from different clinical colleges, they have these sessions, and you have these pharmacological companies coming and doing presentations like we have done this much reduction, this many patients saved. So they have all these charts and things to say, right? So they will say like this, when treated with our treatment, there's a 50% reduction in cases. So they will always say this one, but it is only 1% saved. So it's important to understand these numbers, how to interpret, right? So then we have a problem. So to get this outcome, so we had to treat here 100 people to save one, right? So this number needed to treat. So as a policy wise, so as a government, from the point of government or health administration, we need to know how many people do we need to treat to get this outcome. So that simply comes from 1 divided by absolute risk reduction, right? So here we said absolute risk reduction means when you treat 100, you save 1, right? So 1 case prevented when 100 is treated. In simple terms, that is that number of patients need to be treated for 1 patient to benefit, right? So when we treat 100 here, we save 1, right? So the importance of this is in dividing this, in deciding on the government policies, how many cases can be prevented by treating. Like if it's number something like to save 1 person, you have to treat 10,000. That is not very economical. So in such cases, like they won't have policies to treat like that. So that is how we use that. So I have so another example, if we said you can put different values here and just do by yourself. Just think of different, like if you had 4 and if it was 2 here, right? So if you had 4 people in the placebo group and you had 2 in the treated group, that means again 4 became 2. That means again the relative risk reduction is 50%, right? 4 becoming 2. But now absolute risk reduction, so 4 in the untreated group becomes 2. That means 2 people are saved. So the absolute risk reduction is 2. Percentage wise, it's 2%, right? Absolute risk reduction. And the number needed to treat, so when you treated 100, you saved 2. That means to save 1, you need to treat 50. Is that clear, what I said?
Yes.
Yes.
Yes. Thank you.
Yeah. So always think of it like in this manner. Just visualize like this. So you can get the same answers with different numbers, right? So this aspirin thing, this question, it has been asked in the exam. Definitely you all have seen that already. So it comes from this article. I have pasted the link here, so you can check that also. So they can ask it in different ways. So they can ask what is the relative risk reduction, what is the absolute risk reduction. Then they can ask it in negative way like this. If you don't take aspirin, how many cases will increase, like that. So that is another way, like it is asking the same thing, the effect of aspirin, but they will word it like what is the percentage of cases that will increase because of not taking aspirin, right? So there are different versions that they can ask, but they mean the same thing. So just go through this and do it by yourself. There are all these different versions have been asked. I have seen. So just do that and be familiar with this. So whenever
So
you...
can I get
Sorry?
Can I get the answer for that question that you asked? So, what is the increase risk if this group did not take aspirin in this contest?
Yeah.
Is it
So let's
100% or
now
200%?
if you don't take aspirin, what is going to happen, right? So that is the question. So if you don't take aspirin, this 1 is going to be 2, right? That means 1 becoming 2, so your absolute risk increase is 1%, right? Absolute risk increase is 1%. What is the relative risk increase? It is 100%. So I know that some people took the answer as 200%. It is wrong because now you have 1 and 1 in risk as a relative risk means 100%, right? So it is going to increase by a similar number, right? So 1 is going to be 2. The increment is equal, right? So when they ask, just because of not taking aspirin, what is the risk increase? So it is still going to be 1. So you are going to get 1 MI whether you take aspirin or not. That MI will be there, right? Then just because of not taking aspirin, another one will be added to this group. So the risk is equal to what is already there. So it is 100%. The relative risk increase is 100%. Absolute risk increase is 1%. Okay?
Yes, thank you.
Okay. So just like I said, so these reduction, these words have been added thinking of the protective effect of whatever the drugs and vaccines, but this can be asked in this way also. What is the relative risk increase? What is the absolute risk increase? Number needed to harm, right? So it is just the word difference. They can ask about a complication, like when treated with this many had complications, and they can ask, okay, what is the relative risk increase and what is the number needed to harm, like that. It's the same thing, just a word difference, right? So that part, just go through this question. You all probably have the question with you, and it is there very well described in this link also, the best practice. I have included it here. Just go through and be familiar with that. Okay. And is it okay now? Is it too much like what we have done up to now? Just a
No,
bit of
that's
like
perfect. Thank
2
you.
topics. Huh?
Yeah.
That is good, sir.
Good. Yeah, good.
Yeah, so we will proceed. There's 3 more to do. So this null hypothesis and p-value, just the interpretation of that. Then the epidemic curves, we have to do these charts and this forest plot, right? So I will do this one. So null hypothesis and p-value. So when you are going to check or when you are going to compare 2 factors for a significant association, right? We make an assumption called the null hypothesis, right? When calculating whether there's a significant association between a risk factor and an outcome, we make a hypothesis. Null means no, 0, right? So we initially make a hypothesis saying that this risk factor and outcome has no association, right? That in simple terms, that is null hypothesis, stating that the risk factor and the outcome has no association. That is null hypothesis, right? Then if we identify, when we do this research, if we identify any association, that will purely be due to chance, right? That is purely going to be just luck, right? So that is null hypothesis. Saying that statement is null hypothesis, right? So then our aim is to prove that null hypothesis is wrong. So that's how we are going to find out whether there is actually an association. Proving by the null hypothesis is wrong. Now to prove that, we have to calculate something called the p-value. P-value, now when you calculate, before calculation, right? Before calculation, we decide what the p-value cutoff is, like what is good enough for us. Now in biological studies, all these medical things, we use this 0.05. Now 0.05 means 5%. Now 5%, this is arbitrary. This is just, we take 5% as our cutoff, but there are in other, like maybe in physics or in chemistry, this p-value will be very low, like 0.0001, something like that, right? So different studies, different fields use different cutoffs. So in biological ones, it is good enough for us to have this 0.05. So what does this 0.05 or 5% mean, right? So what it means is that what is the probability that the observed association, so the connection that we saw between the risk factor and the outcome, right, was due to chance. So we said there is no association. We thought initially that there is no association, there is no connection between the risk factor and the outcome. Okay. Then we calculate the p-value and we find out a certain value, right? So what the meaning of p-value means, what is the chance of null hypothesis being right? In simple terms, that is that. The p-value is the chance of null hypothesis being correct. So the arbitrary cutoff that we use is that we say up to 5%. And now what this means is that up to 5%, we will allow this outcome to be because of chance, right? So it means like this. Now, the probability of observed, if your p-value is 0.05, right? That means the probability of this, whatever the observed associations being due to chance is 5%, right? So whatever connection or this association that you saw being due to chance is 5%. So the rest 95% is not chance. It is not just random chance that you saw there is an association. That means there's a 95% possibility that there is an actual association between the risk factor and outcome, right? Is that clear up now?
Yes.
Yes.
Right. So that means there is 95% chance that there is actually a connection, actual association between the risk factor and outcome, right? So that is if this is like, so if p-value was 0.01, that means 1%, right? So if p-value is this, that means the association occurring due to chance is 1%, and there's 99%, the rest is because of an actual association, right? So in medical studies, we take the cutoff as this 5%. We take, okay, up to 5%, we will say it is going to be because of chance. If there is anything more than that, then that means there is an actual association. That is how we interpret this, right? So you do a study, then you calculate and you get the p-value like 0.02, right? So, but in the beginning, you have taken the cutoff as 0.05, right? So now whatever the p-value we identified, the 0.02 is smaller than the cutoff, right? That means there is something more than just because of chance. So the probability of the association that we saw occurring because of chance, right, is only 2% here. If the p-value was 0.02, That means this outcome occurring because of chance is 2%, right? That means then there is another 98% where this outcome occurred because there was actual association, right? Actual association. But in the beginning, we said we are good with 95%, right? So we have already said that. We have already decided that if we find something at least 95, that is good enough. So 98 means it's a bigger value than 95, right? So then we discard this null hypothesis. That is what rejection of null hypothesis. So we say there is actual association between the risk factor and the outcome, right? So null hypothesis, we said there is no association. Now we found out that there is a higher probability like of this connection occurring because there is actual underlying association between the two. So we reject the null hypothesis and discard it and state that there is an actual association between the risk factor and the outcome. Okay. Is that clear or
Yes.
yeah, okay. So that is what you say. Let's take, you find something like p-value is 0.07, right? So 0.07, that means 7%. So you find from the study that the p-value is this. That means the chance that the association, whatever you find, because of the probability, the association between the risk factor and the outcome that you find, due to being luck or just chance, is 7%. So that is not good enough for a medical study. It should be less than 5. So for our use, it should be less than 5. So because this is more than that, we say the null hypothesis is true, right? So that is the meaning of that. So if when we say null hypothesis is true, that means we believe or we accept the null hypothesis and say there is no actual association. Okay. So if you get a question asking, they have compared something A to B and found out the p-value as 0.05 or 0.04. What does this mean? And if there's a statement saying there is an actual connection or actual association between A and B, then that statement would be correct, right? So I think this is in simple terms what this p-value thing means. So do some questions and it will help with that. There are a few with that. There was a question asking the meaning of null hypothesis. So what is the statement that best describes null hypothesis? There was a question like that. And there have been other few questions stating a certain p-value and asking what does this mean, right? Okay. Then with this, there are this type 1 and type 2 errors. This part has not been asked. I just included that for completion. Maybe they might ask later on. So type 1 means now telling a male patient, a male person that you are pregnant. That means you are seeing a connection where there should not be a connection, right? Simply that is that. Type 1 error. Remember it as telling a male one that he is pregnant, right? So you are seeing a connection where there should not be a connection, right? So type 1 error. So null hypothesis is true. That means there is no connection, but you reject it. Reject means you are telling that there is a connection. You are seeing something where there is nothing. Okay. And the other thing is that telling a pregnant person that that person is not pregnant. So you are not seeing the connection, not seeing a connection where there is one. So that is type 2. There is actually, the null hypothesis is false. there is an actual connection, but you accept, you fail to reject. That means you accept that there is no connection. So this is type 1 and type 2 error. Just remember these pictures. It is very easy when you remember these pictures. So this has not been asked. I just included that for completion. So if they have a statement regarding this type 1, type 2, you will be able to understand that. Right? Okay. Is there anything, any issue in this part that?
So for a p-value 0.05, we can reject null hypothesis in
Yes.
medical studies.
Yes.
Thank you.
Okay. Right. So the next one is epidemic curves. Now this is a very recent one, I think, for the last recently seen one for the last 2 months maybe. So epidemic curves shows the frequency of new cases over time based on the date of onset of disease, right? So this is just a graph that shows you the pattern of cases, right? Now this shape of the curve will give you an idea about the cause or the underlying source. Okay. Then according to that, there are these 4 types, common ones, that you can identify. Now a point source is where people are exposed to a certain source. Example, maybe a viral outbreak, or maybe you have a gathering and there's meeting and there's a person with chicken pox in that meeting, and everyone else is exposed and they get chicken pox, right? So in simple terms, that is a point source, right? This is persons are exposed to the same common source over a brief period of time, right? Such as through a single meal, event attended by all cases, like so maybe maybe a birthday party, maybe something like that, right? So in those cases, so number of cases will rise rapidly to a peak, then it will fall off gradually, right? Majority of the cases occur within 1 incubation period. So like this. So this shape, if you get a curve like that, so you have a rapid rise because you were exposed to somewhere here, then you rise, and that exposure, whatever there is, now let's take our chickenpox person. So that person is isolated at home, or he gets treatment and he is no longer shedding the virus. So in such case, only the people who initially got exposed will get the disease, and that will cause a curve, a peak, and they will also get treated and the number will drop. So that is a point source. Anything like any example, if you get in questions, like everyone go to a common place on a single day, right? Like that, viral infection, birthday party, something like that. So they will have something like this. So they will have a peak, then slowly drop down, and that is it. It finishes there, right? But if you can have these smaller ones, like maybe a single block here, if there are that, don't get confused, because in the community there can be some on and off cases, right? So just having some before this peak, having very small ones before that does not change the way, does not change the curve. It is still going to be the same thing. Okay. Then you have continuous source. Now continuous source means this exposure is not confined to one point in time. That means cases are spread over a greater period of time depending on how long the exposure. Now, example is that, think of a place where people go, like a laundry, like, so if you have a public laundry and you have some infective source in that place, right? So everyone is not going to the laundry every day. So people, what they do is, if they are going to a public laundry, so they will collect all clothes, maybe for the whole week. They will collect and they will go on a single day, wash their clothes and come back. So the next day, a different set of people will go, right? Like that, different groups of people get exposed to the source on different days. So there is going to be a sort of similar number of cases throughout this period, right? So it is going to be sort of flat, like there may be small ups and downs, but it is going to be the same number getting reported every day, right? So usually this happens when you have a continuous exposure. Somewhere people get exposed to the disease or the infective process continuously. And it is not going to be the same group of people. It is going to be different group. So it is called continuous source. Just like maybe a laundry, maybe some any common place, maybe a bank, whatever. Like if you go and in infected pool, like say a pool. So people, like if they are not a water park, let's say a water park, amusement park, everyone is not going to the amusement park daily. So some will go today, another group will go tomorrow. So like that. So in such cases, you will get a continuous source, a chart, graph like this. Okay. Right. So then there is this propagated source. Propagated source means does not have a common source, but instead caused by spread of pathogen from one person to another. So transmission may occur directly or via intermediate host. So in simple terms, like what this says is that you have, initially it will start with something like this, a point source where someone, an infective person, is exposed to a group of people, right? And I said in this one, so that initial person gets treatment or gets isolated, and the other people also get treatment and isolated. Think of a situation like in COVID, where people didn't get properly isolated, so it sort of started from one person and it went on like completely spread. So gradually you will have rising numbers over period of time. So it's a propagated source. Okay. Hello.
Yeah.
Yes,
Yes.
sir.
Okay.
Yes.
Okay.
Okay. Then the last one is an intermittent source. Now, intermittent means similar to continuous, right? But it is intermittent, multiple peaks. Now, exposure is like, think you have some elders home or children's home, and there is a food truck delivering food weekly, right? And they are bringing this infected food. So you get a chart with multiple peaks in regular intervals, right? Multiple peaks in regular intervals. So a single peak is something like this, a point source. So it came, the delivery truck came, it gave the exposure. So children got the disease and got cured. Then some time goes. Then again the truck comes on the same day in the next week or next month. Then again there's going to be a peak. Just like that, there will be multiple similar peaks with regular intervals. So if you get a graph like that, so it is going to be a recurring event in regular intervals that is going to cause this infection. So look for something that is happening weekly or monthly like that in the answers. So intermittent source. Okay. So these are the 4 things. This is very simple. Just you can mark this correctly without any issue. So if they ask about any single viral infection, chest infection, a single one, like person getting exposed, then having a peak and drop, then having a birthday party exposed to something, or they go to a place get exposed to something, then just it is going to be a point source. If it is a place, the infective source is continuously spreading to different sets of people, it is going to be a continuous source, like a laundry, right? So propagated means, again, where there is no stopping, there is no isolation in the initial phase or getting proper treatment. So that person will give the disease to one, will give to maybe 5 more, that 5 will give to another 25 people. So it is going to spread drastically. So it can have this exponential type of curve. So that is going to be a propagated one. Intermittent one is a situation where you have similar events occurring in regular intervals, right? So it should be because of a cause that is happening repeatedly in regular intervals. Okay. Yeah, so that is about this epidemic curves. Simple, just you can mark that very easily in the exam there. And the last thing, this is the last one. Sorry I think I have taken a lot of time. So graphical display. Now, to graphical display of meta-analysis, now I said the best evidence comes from meta-analysis. And to give, graphically, to give a good display of the outcome of meta-analysis, there are multiple, graphical graphs and tables you can do. So forest plot is a very common one like that. So there are other ones called funnel plots. Then there are box plots. There are different ones, like scatter plots. But the forest plot is the very commonly used one, and it has recently been asked in the exam. So what you need to know about the forest plot. Now, this example I have put here, it comes from this article. Just you can look at that also. So in a forest plot, there are going to be these lines, these horizontal lines with a box in the middle, right? Now, each line with a box represents a single study, right? So we said a meta-analysis is a collection of similar smaller studies which are assessed, and the data is filtered to give an outcome, or identify the best evidence out of everything by analyzing together. So this included single studies are given by each of these lines, right? So each single line with a box represents a single study. Okay. So here there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, about 17, right? So then this box, the size of the box is different in different studies. So the size of the box refers to the outcome, the size of the outcome of the, so that means the effect of the final effect of the study. How big is the study? And also it reflects the population size. So bigger the population you have, bigger its outcome going to be on the final result, right? So there are smaller ones and there are very bigger ones. So here, like that, each horizontal line with a box in the middle represent a single study. The size of the box in the middle of a line represent the size of the study population and thereby the size of the effect, right? Then you see this line, the length is different. So you have shorter lengths, you have longer lengths. So the length describes the confidence interval, right? Now you can see here it's the odds ratio. So this vertical line in the middle represents the odds ratio equals 1, right? So OR equals 1. So this can be odds ratio, this can be risk ratio, that means relative risk. It can be any of those two, either odds ratio, relative risk, those are the commonly used ones. So here, then there you will have a vertical line that represents this point. So this confidence interval I said it can have different values like 0.7 to 1.2. So it can be something like this. Here it's 0.7. Here is 1.2. So a longer one, this may be 0.01 to here 10. So like that. So the length describes the confidence interval, the range of the confidence interval in every single study, right? Then you have a diamond. The diamond shape represents the overall effect of all the studies, right? So there's a diamond. Now you have two here. Now it represents two outcomes, right? So whatever it is, now this diamond represents the outcome of all these, right? All these 17 here. So what is the outcome of the meta-analysis, right? Then I said, when we did this case control once, if your odds ratio equals 1, right? That means there is no significant odds, right? And if the confidence interval crosses the value 1, I said that it is not going to be significant. Whatever the odds ratio you find, it is not going to be significant. And that concept comes into play here. So if your confidence interval crosses the odds ratio equals 1 line, that means it is not significant. So if you see, each of these studies, single studies, has a confidence interval for the odds ratio that crosses the value 1. All 17, right? So if everything crosses the value 1, the final outcome also should cross the value 1, right? So this the final outcome of the meta-analysis says that there is no significant association or risk in whatever we have been looking through all these studies, right? So if the diamond crosses the vertical line, then the overall effect of all the studies has not proven a significance, right? So that is that. So here it was something regarding the use of furosemide and furosemide in patients with renal failure regarding their mortality. So the furosemide has no significant effect. That is the outcome in this one, right? Is it clear?
Yeah.
Yes.
Yes,
Yes.
sir. It's clear.
Yes.
that is basically a forest plot. So if you get a question like this, just look at the diamond. If the diamond crosses this vertical line, this whatever, it may be a relative risk, it may be a odds ratio. If it crosses this, that means there is no significance, right? So if it asks about the single studies, you can check how many of them cross this line. So if the confidence interval of all these studies cross the line, so that means they also don't have significant effects. Sometimes you can have like 1 or 2 crossing this vertical line, and some may be here, like they have actually an effect, right? So just look, the concept is like that. If it crosses, it has no significance. If it does not cross, then it has some significance. But depending on how many studies have this significant value, you will have the outcome of the diamond. If the diamond does not cross the vertical line here, that means the meta-analysis, there is evidence from a meta-analysis that there is a significance in the findings, right? Whatever the risk factor or the cause that we are looking into. So that is how it is described. Right? So this is the last thing. That's all. So this, I think I went through